Welcome to the APAPP podcast. I am Corinne. I'm a nurse practitioner and the president of the Association of Pulmonary Advanced Practice Providers. And today's podcast is Biologic Breakdown. And with us today is Amanda Michaud. She has been practicing as a PA in asthma, allergy, and immunology since 2013. She holds board and leadership positions within the Association of PAs in Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology. She currently practices at Family Allergy and Asthma Consultants in Jacksonville, Florida. And I was lucky enough to do a deep dive into cytokines podcast with her with NACE. So that's another podcast you can listen to if you don't get enough of biologic therapies and cytokines in today's discussion. So Amanda, thank you so much for joining us today.
Thank you so much for having me. I'm excited to talk about this.
All right. And Amanda, I toot your horn all the time. I think you're an amazing educator and teacher. I'm so glad to have you. And for those of you that were at our conference in 2024, Amanda did a great session on immunology of the lungs. We're having her back again this year for 2025 conference. So hopefully you'll be able to join us in Nashville in June. So we're recording this at the end of the year, just for reference for anybody that might be listening to this later, because things are always changing in the biologic space. So let's start with the biologics that we currently have. How many are out there, and how do you kind of approach looking at those biologics for your patient?
Yeah, there are now 6 biologics available for treating severe asthma. And, it just added to, our ability to better target and treat our patients with this awful disease. Out of the 6 agents, we've had omalizumab for a long time, that's Xolair. And this is anti-IgE. We'll talk a little bit more about, how do we choose what in a little bit, I'm sure. But that targets IgE. There's dupilumab, which targets interleukin-4 and interleukin-13 via a shared receptor on that site. There's also mepolizumab and reslizumab that target IL-5. Reslizumab is IV, perhaps not used as much anymore these days, but when it first got approved, we used it quite a bit. And then there's benralizumab, which works quite similarly, but not quite the same. But this targets the IL-4 receptor on the surface of the eosinophil. And then our newest one is tezepelumab, which targets thymic stromal-lymphopoietin, or TSLP, because I'm not going to say that over and over again. So we'll call it TSLP. So we have 6, and they all have different indications as far as age and dosing regimens and all of that. It's kind of hard to keep it straight. It's good to kind of have a little cheat sheet in your office. But a lot of times when you prescribe these patients, it kind of walks you through what dosage they would need.
Excellent. And did you cover dupilumab? Did I miss that?
Yes.
Okay. Sorry. There's so many maps. We just want to make sure that we cover all of those there. So let's start with the IL-5 family, because that seems to be where the bulk of them are. You get reps in your office and they're talking about how their IL-5 is different than others possibly. So do you see a difference in IL-5s, or how do you tell the difference between these IL-5s and where they may work best?
Yeah, early on, I didn't really think I saw much of a difference, but as years have gone by, I definitely have a lot of patients who are on, the dosing regimen for benralizumab. It starts at every 4 weeks for the first for the first 3 injections, and then it goes to every 8 weeks. And I used to use that quite a bit and had a lot of good success with it. I still do, but really over the last several years, I've had more and more patients that have noticed breakthrough symptoms when they get to that every 8-week dosing. So I've had more success over the last several years with mepolizumab being every 4 weeks. I just have a lot better control and maintenance of that control with my patients. And I know a lot of colleagues can kind of echo this as well. Not knocking benralizumab, of course, it's still right for the right person. Again, that's that kind of shared decision we have with patients. Some patients will still have such a great response that every 8-week dosing doesn't matter and they still do great and they're happy. But that's kind of what I've seen lately. The reslizumab, since it's IV, we just really aren't using that very often, with some exception maybe for a patient who really is an anti-IL-5 candidate who, let's say, is quite overweight or obese. Because reslizumab does allow us to do weight-based dosing, there is some theory and some evidence that this may be more effective for that patient population. But personally, I haven't utilized it. I haven't needed to. I've had good success with the others. And, I'll take a step back and think about, before we get into even more of this, when we think about, we have that severe asthma patient, right? And first, we always confirm it's severe asthma. We check their inhaler technique, all that stuff. Make sure we're ruling out other conditions that can contribute to poor asthma control, like exposure to triggers in the environment, like allergens. It's always the cat. I say that all the time. It's always the cat in allergic asthma, at least. And then, you're checking that inhaler technique. You're making sure they're getting their medicine and taking it appropriately. And then you're left with that, right? That true severe, moderate to severe asthma, depending on which kind of patient you're looking at. And then based on their age and their other T2 comorbidities, we'll talk about that more too, probably. We then decide, okay, we got to check these biomarkers. And biomarkers, there's a couple different ones that we use in clinical practice. Eosinophils, I feel like, are kind of the top of the decision tree. So we check absolute EOs. We check a total IgE. In my practice in the allergy clinic, we're doing allergy testing, preferably skin prick testing. It's a little bit more sensitive and specific, but serum IgE testing is fine too. And then we do a lot of pheno as well. I love checking phenos on my patients because it really, really does help us with this algorithm of what might be best for them. And then even though FEV1, of course, isn't really considered a biomarker per se, I think it's important to track that, of course, because even if a patient has a normal FEV1, right, they can still have pretty severe asthma. And that's important to kind of track their effectiveness of that medication over time, whichever one you choose. So those are kind of the things that we're thinking of checking initially. And sometimes we'll see that new patient immediately and we'll know, all right, this patient needs a workup for biomarkers. And we order the labs right off the get-go.
Yeah. And those biomarkers that you mentioned to review for everyone, as far as the absolute eosinophil count, what would you consider elevated?
Elevated is generally considered 300 or higher, 400 in some publications, but in general, we're using 300 as our cut point. The 150 to 300 range is kind of like that intermediate group, and then low is definitely anything below 150.
Okay. And I know a lot of the FDA approval for these therapies was at 150, but we're seeing more and more literature, I'm sure you are in the asthma allergy field too, that the higher their EOs are, the better responders they are going to be to that therapy. Those are the patients calling you crying, leaving you in the will, bringing you cookies, because this is the best they've felt in decades, kind of a
It's
thing.
amazing.
Yeah, those are usually those high EOs patients. Yeah.
Yeah, really, the higher the EOs are, the more at risk they are for severe exacerbations and hospitalizations, but then the better their outcomes generally are. And it's great. And all of these biologics we have available generally work better at those higher EOs, even though there are some that are indicated for non-T2 asthma, irrespective of EOs. But we see that as well. And, like you said, they're the patients that are calling you like a week later, already feeling amazing. And we really have the ability to change their lives with these drugs. And it's amazing.
Yeah. I do want to go back also to what you said about the other biomarkers. So, elevated eosinophils, that would indicate type 2 inflammation or T2, Th2. You might see literature kind of expressed that way. And then pheno and the IgE RAS testing, skin prick testing would speak to you a little more about allergic, right? So you can have eosinophilic allergic, and then you can have that combination of patients as well. So I'm glad you brought all of those up because they all need to be kind of looked at. They all fall under that Th2 category. They can have one, the other, or both, right?
Correct. And it's really the patients that have that overlap that are probably the hardest to figure out which one's best. And even though we have a medication, a biologic tezepelumab that theoretically treats all comers, it's very important to target it as specifically and as direct as possible. So if you're targeting TSLP, you're more upstream. But if a patient might be better on an anti-eosinophil or what we call anti-IL-5, we kind of call them anti-eosinophil drug, then they're going to do best on an anti-IL-5. And that's why the biomarkers are so important. And sometimes even a patient on tezepelumab will not get the robust improvement we're looking for. So it's important to factor in the whole picture, their biomarkers. If they're allergic or not, pheno can help drive our decision tree as well. But it's important that we target it as specific as possible for multiple reasons. One, because they're likely going to have the best chance for the best amount of improvement, the highest efficacy we can get. And even though we're all comfortable with using these biologic agents, because we know they're really safe, thankfully they have really good safety profiles, they're super effective for the right person. We're not trying to prove efficacy. We know they're effective, right? But for patients, it's a big deal. And sometimes it's a tough sell to get them to commit to starting a biologic. And you got to make sure you get it right the first time. You really have to think about the inflammatory cascade and go back to kind of that picture, if you need to, of all the different cell types involved in it. It gets more and more complicated every couple months generally, because we're learning more and more about different pathways in asthma and the immune system, how complicated it is. But getting it right the first time, assuming they tolerate the medication, is so important. And so, yes, it's great to have an option like tezepelumab, which I love to use for the right patient and works great for them. We really need to focus on how to target them as best and specific as possible. And that is not just biomarkers, it's also their history. The classic child with allergic asthma who spends a lot of time outdoors, who has a couple pets that they're allergic to, they will very likely have both elevated EOs as well as elevated IgE, and of course positive testing to aero allergens. And they still may do better on omalizumab than the other agents, even though they meet the criteria for all the others. So it's super important to us. And I know not everybody feels as passionate about this as I do, or perhaps we do, but it's really, really important to kind of get it right the first time for us.
Well, let's say you don't get it right the first time. Like, can we talk a little bit about switching therapies? I'm looking at Tezi a little different now because there's just recently been some articles discussing really high EOs and Tezi response, and which we're seeing with a lot of other biologics as well. So originally, when Tezi was launched, one of the promoting factors that they used was that you do not have to have elevated eosinophils or really any other biomarkers to qualify for therapy. So maybe your patients who were on a lot of oral corticosteroids who didn't have an elevated eosinophil response because the steroids were keeping it down, oh, you're having all these exacerbations, you're on everything else there is, I could qualify you for Tezi, right? And we
Exactly.
did see, at least in my own practice, reduced exacerbation rates, but they weren't having that, oh my gosh, I feel amazing kind of response that we saw with some of the other therapies. And now I'm avoiding Tezi in patients with lower EOs because we're not getting that correct response, and then going maybe with some other therapies for those patients. And maybe looking again at really high EOs for Tezi patients. But if we don't get it right the first time and we decide this is not the right therapy for patients, are there any guidance that you could give us about switching therapies and staying within the same class of biologic or going outside of that? What would your recommendation be?
Yeah, whenever if we feel like we're getting it right and a patient doesn't respond, I always like to take that step back and think about, what are we missing? Like, is there something else that we overlooked previously? So that's where it can be helpful, even in the what seems like maybe the classic Tezi patient, to still check biomarkers, because you can compare to what they're looking at now, or pheno, things like that. Tezepelumab, dupilumab should all impact pheno. So you can kind of really monitor, all right, this patient's pheno went down. Why aren't they getting better? Or their pheno didn't improve for whatever reason, and that they need to switch. So in general, I'm looking at a 4 to 6 month trial. And then if they're not improving the way we've hoped, and a lot of times these patients with that overlap, that meet all the criteria for all the different biologics and really could do any of them, a lot of times they do get improvement, like you said, right? But it's not that, oh my gosh, this is amazing improvement. It's like, yeah, I'm better, less exacerbations. I'm not getting steroids as much, but I'm still having lots of daily symptoms, or I'm still, went from 6 exacerbations in the last year to 3, which is still a lot. And, we take that step back. I'll usually reassess the biomarkers and then go back to kind of that mental algorithm that we follow and think about what would be best for them. If they were on, let's say, benralizumab and doing it every 8 weeks, I'll kind of discuss with them, do you feel like the first month you do better and then it wears off? And that's how we've discovered a lot of patients that might do better on that every 4-week dosing. If it's completely just been really not super effective at all, then it's more likely beneficial to kind of take that step back and look at a different class. And that's where we can also think about the other historical factors in the patient's life. So, like, I'll give a great example. A patient that, let's say, is on an IL-5 or dupilumab, and they don't have that robust response. But then in talking to them to kind of figure out what's going on, they tell you, they're super exposed have a lot of exposure to different dusts and fumes and fragrances and smokes, those different what we call non-specific triggers. They do really well on targeting TSLP. So a patient might meet the criteria perfectly for an anti-IL-5, let's say, but they'll tell me they have a lot of non-specific triggers, like everything seems to set them off. And those patients do really well on tackling something way upstream where those first, organisms and compounds come into contact with the skin or rather lung barrier and, targeting that alarmin before it sets off the whole alarm and inflammatory cascade can be more helpful for them. So it's tough when they don't respond because we don't want to be discouraged, but it can be discouraging. Like, man, I think I got it right, but then, you didn't. But after 4 to 6 months, you can switch therapies. There's no need to, taper off one and restart another after X amount of time. You can just get them on another drug. And theoretically, mostly they haven't been studied this way, but theoretically in clinical practice, it is okay to use more than one biologic. But reality is we're not going to be able to get insurance coverage for more than one biologic. So that's always tough when patients have kind of that mixed kind of profile there.
I would say allergy, you guys definitely are the pioneers in combining biologics. I'm too chicken to do it. So oftentimes I'll say, you know what, I'm going to send you to allergy. They might combine therapies for you that I'm not brave enough to do. So I'm glad you mentioned that piece of it. When you have a pediatric patient versus an adult patient, do you approach those any differently in how you're treating them? I know you said you don't have any children on IL-5s.
Yeah, even though we have indications for omalizumab, dupilumab, mepolizumab, and benralizumab for 6 and up, and then Tezi's now 12 and up, I don't have a lot of patients that are not, or rather, let me rephrase this, sorry. I don't have a lot of patients that are on anti-IL-5s. And that could be for multiple reasons. In my practice, we see a lot of the other allergic comorbidities. So we're seeing kiddos that have allergic rhinitis, that have severe AD. That's where a lot of this comorbidity comes into play. They also might have IgE-mediated food allergy, and that really does help to dictate our decision making. In kids also, we're a lot more aware of the multiple injection and dosage and how that can impact. And that can impact adults who are busy and have a life and work and all that stuff too. But in kids, it's just, it's different. A lot of them no one enjoys getting poked with a needle, but it's tougher in children. So a lot of times we'll try to be a little bit more conservative about how frequently they need to be dosed. And that can help us stick to or choose a therapy. It's that whole shared decision kind of buzzword that we'll use. But, a lot of our patients, I would say probably most commonly, we're seeing a lot of kiddos with atopic dermatitis that is also severe enough to warrant biologic therapy. And so that patient with both asthma and severe AD, we're going to choose dupilumab more frequently than perhaps other therapies, even if they meet the criteria for, let's say, an anti-IL-5. We know that that's not going to treat their AD as effectively as dupilumab will. And even though dupilumab potentially might not perhaps be the best for their asthma, it's the best fit for that patient because it treats both conditions. And they're still going to respond very likely. They're still going to have significant improvement. As far as, the kiddo with severe IgE-mediated food allergies, omalizumab or Xolair is also now approved for IgE-mediated food allergies to help prevent anaphylaxis from accidental exposures. That's another kind of thing we're weaving into our discussion with patients and parents about if they don't really have AD, we're talking about this as an option. A lot of those kiddos with asthma also have allergic sensitization to driving it, of course. So they might have a better outcome with omalizumab as far as treating both. But it's tough because, every family is so different, right? You have these discussions with families and patients and you try to guide them with what's best. And ultimately, what's most important to them might be, you know what? Wow, we really want to treat this AD. We're really tired of using topical steroids all the time, even though you might think an IL-5 might be best for them. Or, wow, you know what? The idea of being protected to food allergic reactions is great. We've had 3 accidental exposures this year that led us to the ER. We want to do that one. And then pending, of course, if they tolerate the drug and side effects. I recently had a patient that developed some side effects on dupilumab, and the next best choice for her was omalizumab. So normally that wasn't our first choice, but it was better than the side effects she was experiencing on the other agent. So I think with the peds population, we're always factoring in those comorbidities, but we're really factoring in more of the discussion about what that looks like for that kiddo to do that drug.
Okay. And adults, I'm sure you do the same with chronic rhinosinusitis with nasal polyps and eosinophilic esophagitis. I just had a
Yes.
patient who I was trying to get biologic therapy for asthma, but they just had been on and off steroids long enough that their EOs just weren't quite making the level that I thought they'd benefit. And then they just got diagnosed with the eosinophilic esophagitis. So I was like, yes. And they're starting you on that
There you go.
this is great. This is going to help your asthma too. So
Yeah.
when you're looking at those overlapping comorbidities, could you maybe run down which therapies are approved for things outside of asthma?
Yeah, so omalizumab is approved for obviously allergic asthma, like we're discussing. It's also approved for nasal polyposis. It's not really considered as effective as dupilumab for nasal polyposis, but it still has that indication. It's also approved for chronic urticaria, as well as IgE-mediated food allergy. In our practice, we see a lot of patients with CSU or chronic spontaneous urticaria, so that's another consideration there. It's all about simplifying the treatment regimen for these patients. Dupilumab has 6 different indications now, or yeah, 6, I believe. So asthma, atopic dermatitis, nasal polyposis. It tends to be our treatment of choice for nasal polyposis. EOE, prurigo nodularis, which is something that I don't treat, but our dermatology colleagues do. And then COPD with an eosinophilic phenotype. So when we've had those patients that maybe have some overlap or that smoking history, and even if we don't really know if they have overlap or not, a lot of times they'll do better on dupilumab just by default. Mepolizumab is also approved for nasal polyposis, asthma, and EGPA or Churg-Strauss syndrome. In those patients, they'll present with, really high eosinophils. They might have some other extrapulmonary manifestations, but we're treating their asthma and the rest of their disease with this anti-IL-5s typically. And tezepelumab is under research and investigation for nasal polyposis, AD, and some other things too. So I'm excited to kind of see where that goes because that'll just be another option for our patients with comorbid conditions too.
Okay. Very
I
cool.
might have forgot a few in there,
I
but
think Benra, because Benra just got the indication for AGPA
oh, that's right.
recently.
Yes, I knew I
Yep.
was forgetting one.
Yeah. Benra
I need to-
just did. Yeah. And I think dupilumab has a study ongoing maybe with that. And yeah, there's lots to come. So speaking of things to come,
Yeah.
could you talk to us a little bit of what is kind of in the pipeline, what we might be hearing more about in 2025?
Yeah, I think the biggest one at like the allergy conferences that we've been so excited about is the longer acting anti-IL-5s. And I'm going to butcher this name. I wrote it down here.
Gripamocumab.
Thank you. Depemokimab. This is a long-acting anti-IL-5 with apparently enhanced binding affinity to the receptor. And some trials, phase 3 randomized trials, showed significant reduction in exacerbation rates on this medication versus placebo, and was overall pretty well tolerated. And it was dosed every 6 months at 0 weeks and again at 26 weeks. So that's pretty cool because weaved in all this discussion with patients is, how much is it going to affect my life? For us, we like to do most of our respiratory biologics in the office. We find that it keeps us available for the patient. It keeps us, monitoring them. It keeps them more compliant and consistent. And there are exceptions to that. But in general, we like to do it in the office setting. So this is going to be huge for all of these patients. Well, if the efficacy is similar or close to the anti-IL-5s that are out there, who's not going to choose an every 6-month therapy? So that's pretty cool. There's also a couple anti-IL-33s being in the works or being studied actively now. And this is IL-33 is an alarmin kind of up there with Tezi at the epithelial barrier of the lungs. And they're looking at both asthma and COPD, I believe.
Uh-huh.
And the two that come to mind there, itepekimab is one of them, and there's another IL-33 ST2 antibody, astegolimab, that showed improved symptom control and quality of life outcomes. And itepekimab also showed reduced exacerbation rates as well. And I think with astegolimab, they did phase 2 studies. Their phase 3 studies are ongoing. In the phase 2 trials, they showed that every dosage of it was superior to placebo. And itepekimab, in their studies, they actually compared it with dupilumab as well as in conjunction with dupilumab. And what was really interesting about that was that both itepekimab and dupilumab monotherapy was preferred over combo. So that was kind of interesting to see. So I think it's just nice to have more options, and especially if they're also looking at COPD, which is not really something that I treat in my practice, but naturally we have a lot of patients that have some fixed airway obstruction and overlap in the allergy clinic too that we feel comfortable managing as long as they're improving. So it's just great to have other options for patients. And with the astegolimab specifically, the anti-IL-33, they did show results regardless of eosinophil number. It was all similar. So that's pretty cool to have another option that might treat all comers theoretically.
Right. Yeah. Lots of new and exciting things coming for sure. One other thing I wanted to harass you about, since you're our immunology, asthma, allergy person, is the immunotherapies.
Yeah.
So I know when I get a asthma patient new to me that's not had anything done, I'll send them for the biomarkers. Now, my office is just a poor, lowly community pulmonary practice. We can't afford to be now. So for the allergic workup, we're doing IgE, and we'll do a RAST test, a
Mhm.
regional RAST lab. So we're not doing skin poke. It's just a blood draw, serum draw. Ours for our region, they're usually regional, is the Rocky Mountain RAST. Every now and then I accidentally get a Rocky Mountain spotted fever result if the lab's not reading it right. But Rocky Mountain RAST for us, and it'll go through dust mites, molds, some grasses, weeds, trees, cats, and dogs are on there too. And we kind of get an idea of what's going on there. So sometimes I get it back and there's a few lowly positive items. The IgE is a little elevated. My absolute Eos are elevated. Okay, you're type 2 and you're allergic, and I'm going to talk to you about these therapies. Other times, my RAS test comes back a dumpster fire of they're positive for everything at very high levels. And then I say, I'm sending you to our allergy and immunology colleagues because I don't know if immunotherapy would be better for you than biologic therapy. So, how do you guys decide who's a better immunotherapy versus uh, biologic therapy patient?
Honestly, the first thing that we look at is their control. So if we're really truly talking about a biologic patient, it's not safe or appropriate for them to start immunotherapy unless their asthma is controlled. So our discussion with those patients will be, hey, we're going to start you on this biologic therapy, but there's evidence that this therapy, immunotherapy or allergy shots, can change your immune system long term, reduce your sensitization or symptoms with allergic exposures. And the end goal is eventually to get them on immunotherapy, which may also help control their disease long term. And then they can reduce or wean off their biologic. And we sort of use the biologic as a bridge, so to speak, to keep immunotherapy safe for them. Uncontrolled asthma is one of the biggest risk factors for anaphylaxis in the allergy shot population. And it can happen in people without asthma, but that's one of the biggest risk factors. Now, the mild asthmatics and maybe the moderates that are controlled, even if they're on like high dose ICS-LABA, but if they're well controlled, we have no issues starting them on allergy shots. And a lot of times, they also have severe sinus symptoms perhaps and rhinitis. So even if their asthma doesn't improve substantially, they'll still be very happy and satisfied at the end of that they're able to have reduced symptoms, less sinus infections. You think about the unified airway hypothesis, and we know that if we don't control the upper airway, the lower airway is never going to be fully controlled. And I discuss this a lot with my patients because, they come to us and they have lots of rhinitis, they've got bad asthma. They're on an inhaler, their asthma's better, but they're not doing anything in the nose. Nasal sprays, our first line, intranasal corticosteroids, first line, antihistamines typically don't do very much. And so, if they start a nasal spray and they're consistent with it and they do well, allergy immunotherapy is like an option. But there's substantial evidence, especially in pediatrics, that we can change the trajectory of their disease long term. And allergy immunotherapy can reduce the chance that they develop new allergens. And already these are people that, like you said, are dumpster fires, they're allergic to everything. The more things someone's allergic to, the better chance we have that we can really, really help them. So those are some of my favorite referrals, honestly. Um, there are a lot of non-allergists that do allergy shots, and we really recommend not seeing a non-board certified allergy group to do allergy immunotherapy, just because we want to make sure it's done correctly and done right. And there's a lot of kind of weird things out there. But you know, once they start allergy shots, it can take sometimes as soon as 2 months in kiddos, especially, to 6 months to a year for them to notice improvement. So we're always making sure we're managing the asthma as well. And then once we feel like their asthma is good control, they've been on their maintenance dose of their allergy shots, then we can think about, all right, let's reduce your biologic. Maybe we go down, if they're on dupilumab, maybe we try to go every 3 weeks or every 4 and spread it out and see how they do. And they may no longer need it depending on the situation, especially if they're truly that really straightforward allergic asthmatic patient, in our pediatrics especially.
Thank you. That really helps, because I was worried that, are we doing the best thing by jumping straight to biologic therapy, or should we be getting you guys involved? And that makes a lot more sense, especially if they're uncontrolled. Maybe we get them controlled before we send them over, but I know you guys do a great job of controlling them as well. So,
Yeah,
and
it's one of those things where we're always working with our palms, our derms, everything. Sometimes the patient will already be on a biologic and they're just coming to us for allergy shots or considering that. And I'll ask them, you can continue to see us to simplify things, but you already have a great rapport with your pulmonologist. You're set up with them. They're managing this. It's already got the prior auth, all that confusing, complicated stuff. Why don't we just manage the sinus stuff? So we work pretty well with a lot of our community pulms to make sure that they're getting the care they need. Yeah.
great point that it's okay to share, these patients. I know initially I was very confused about sending a patient to an asthma allergist when I was taking care of them in the pulmonary space. But once you start getting connections with your local immunology asthma person, it really is so helpful for, just like you said, you guys can control all the other allergen issues that are outside of the lungs that, we try. It's like, oh, I tried Flonase and an antihistamine and a leukotriene inhibitor. You didn't respond. No longer my problem. I'm sending
Yeah.
you to ENT and
Send them to us.
allergy because I
Yes.
know it's
Yeah. And that's
bothering your asthma.
common. We have a lot of really good pulmonologists that we refer to in this for the same or for different reasons, right? When we feel like, okay, there's something else going on in the lungs. This is not asthma is really the only, with the exception of a few patients that might have like bronchiectasis and immune deficiency, but a few patients, even then we're usually consulting pulms. ABPA, perhaps they're also seeing pulmonologists. So for the straight asthmatics, we're definitely comfortable managing them. But for a lot of those other conditions that can either coincide with, go along with, or part of asthma, or asthma's rather a part of them, we always want to share and make sure we're not missing anything from our perspective too.
Mhm. Yeah. Now, how about resources? There's so much information, and I know some people are listening to this on their commute, or they're, on the treadmill or something. They're not able to take a lot of notes. Are there resources that you would recommend for them?
Yeah, we were talking about this earlier. There are not a lot of resources that really, really walk you through how to use which biologic and when. And UpToDate has a very simple algorithm that walks you through that you can kind of follow based on their eosinophil level, pheno, if you have that, and kind of where to go. Um, and in general, the rest of the resources that I've come across, besides you being at conferences where someone else has put this together, have been other articles published in different journals like Chest, or there was one in the Lancet several years ago, in the allergy journals, that really are titled How to Choose Which Biologic. And it seems like every year there are like 10 more of these articles because we have more and more biologics coming out, or more data supporting, use in different populations or specific patient situations. And for me, it was just very helpful going through, reading those articles. There's often a case presented, trying to figure out which one would I put the patient on, and then reading the rationale. Chest has a really good one that came out in September 24 this year that went through a patient scenario, your initial choice, and then tweaked the scenario as the article went on. okay, now what if this patient had this? Now what if the patient started saying this? And then now she comes back and there's this. And so that's really helpful to kind of think about, because we see these patients in practice all the time. It's never textbook or straightforward. Most of these patients fit, either they don't fit have any of the biomarkers, or they have all of them. And you have to figure out what's best for them. So I think if it can be validating for others to feel like they can't find a lot of resources, it's just there's not something super great out there. And, it's because of, I think, these biologics having so many indications and showing that they're effective amongst these different groups, high EOs, medium-ish EOs, IgE. They all these manufacturers and the researchers look at all these markers and they show, well, ours helps with this too. And so in the real world, it's nice to have those kind of applications of cases that you can look at. Medscape has some good ones, peer review CME, some kind of different online free CME you can find about biologics. NACE, we did one on cytokine origins, and that's a little bit more complex than just choosing per se, but it does kind of get into that too. But really just familiarizing yourself with, how these patients present. And even if they have allergies, are the allergies even relevant? Do they have one or two allergies that wouldn't explain their symptoms? Or are they really allergic to everything? All those different things can help. But reading as much as you can is probably the best.
Yep. It's always making time for that reading. It never ends. Huh?
It never ends. Yeah,
No.
That's true.
Yeah. Well, biologics are keeping us in business for sure. And Amanda, I'm so glad you're here to help us understand it. So thank you again for joining us today.
Yeah, thank you so much for chatting with me about this. This is great.
All right. Well, thank you guys for listening. Don't forget to like, subscribe, share the podcast. It's the best way to support APAPP, and we will see you for the next episode.